Well, welcome to Headache School tonight. I am Dr. Pham. I'm one of the headache faculty at the University of Utah. And today we will be talking about occipital neuralgia. So is occipital neuralgia causing my headaches? I don't have any disclosures relevant to this talk. And so for today, a few objectives I want to cover is what is occipital neuralgia? Who gets occipital neuralgia? What are the signs and symptoms of occipital neuralgia? Are there any tests to find out if I have occipital neuralgia? How is occipital neuralgia treated? And what do I do if I think I have occipital neuralgia? So we'll start with the first question, which is, what is occipital neuralgia? So forgive my drawing skills, but this was really actually challenging to do with a trackpad. But here's a little diagram, kind of cartoon of a person, the back of their head. You see these yellow lines that are kind of coming up, and we have labeled here the greater occipital nerve and the lesser occipital nerve. And then that other one, third one that's coming up kind of the middle is the third occipital nerve. And these would be on both sides. I only drew it on one side. Otherwise, I thought the image would get too busy. But these are main cranial nerves that bring sensory information into the brain. And so they're really important when it comes to headache and pain. Because when these nerves become irritated, then they can cause pain, in particular in the distribution of those nerves. So when we think about what is occipital neuralgia, we turn to our diagnostic criteria, which is housed in the International Classification of Headache Disorders. Currently, we're at the 3rd edition. And so the way that occipital neuralgia is defined is that you have pain in one or both sides of the back of the head in the occipital nerve areas. At least 2 of the following. The pain should be either recurrent in paroxysm, so it occurs a few seconds long to minutes long, or it's severe or shooting, stabbing, or sharp. And so 2 of those. And then you need to have either abnormal sensation, so dysesthesia is a term for that, or pain to non-painful stimuli, which is called allodynia, of the scalp or hair, or you need to have tenderness over the affected nerve branches and or trigger points where the occipital nerve emerges, so the base of the skull and neck. The trigger point is an area of muscle that you push on that is tender to palpation, so tender to pushing on it. And then it needs to be temporarily alleviated by a nerve block. So another way to think of this effectively is either irritation or compression of the occipital nerve. And this could potentially be in relation to chronically contracted muscles, trauma to the area, bone or skull deformities, Chiari malformations, arteriovenous malformations, which are little abnormalities of blood vessels. And so that's a way to think of it. It's irritation of this nerve that runs up the back of the head. And often people are feeling the pain at the back of their head. So who gets occipital neuralgia? The actual incidence of the number of people per year that have this isn't all that well known. There was a Dutch study that does report about 3.2 people per 100,000 people. My guess is that this is an underestimate, and it's not real well documented. What we do know is that there tends to be a slight female predominance, and it accounts for about 8% of cases of facial pain. The average age of diagnosis is about 54 years old. 90% of the time it occurs in the distribution of the greater occipital nerve. So you think back to that diagram, that was that bigger one kind of coming up the back of the head, and 10% in the lesser occipital nerve, which is that one more off to the side. And so most of the time it's on one side, but a third of the time it could be on both sides of the head. So then we want to think about, well, what are the signs and symptoms of occipital neuralgia? So when we think about this, signs and symptoms of occipital neuralgia, think of symptoms as the symptoms that you are having, and signs are the examination or test findings. So symptoms would include stabbing, head or neck pain. Often it starts at the back of the head, moves to the top of the head. People can have eye pain, and this is referred pain because some of the nerves that come from the cervical spinal level too, so just a couple inches down from where the occipital nerve main kind of branches are, can kind of lead to that referred pain. And then people could have ringing in the ears, dizziness, nausea, even nasal congestion has been reported. And so this can make it kind of confusing because some of our primary headache disorders like migraine or hemicrania continua could have similar symptoms to this. And then signs, so your exam or test findings, there should be tenderness along that nerve, and then kind of an abnormal sensation, so that dysesthesia in the distribution of the nerve. There could be tingling from light pressure to the nerve, pain with hyperextension and rotation. So this was kind of coined the pillow sign. So if somebody lays their head back on a pillow and they've extended it back, and then they rotate their head, that could create pain. And then having improvement with an occipital nerve block, and ideally twice, because there is 40% false positive rate with having just one nerve block, because other conditions like migraine or cluster headache can actually respond to occipital nerve blocks as well. So many clinicians feel if there are two times that somebody responds, it's more likely to be occipital neuralgia, though it's not necessarily a guarantee. So are there tests to find out if I have occipital neuralgia? Not really. We talked about nerve block. So, you'll want to have relief from the pain with a nerve block. Hopefully this would be 2 blocks, and then that is more confidently thinking of occipital neuralgia rather than migraine or other headache disorders. Again, that's not a guarantee. And then depending on the examination, so when we do a neurologic exam, we look for, strength and sensation and your reflexes and a lot of other things. And so if there are abnormalities on that neurologic exam, depending on where those abnormalities kind of map out on the body, different parts of the brain and spinal cord are responsible for doing different things. So based on the exam findings, it may tell us, hey, we should look at a brain MRI or a neck MRI to see if there are other kind of structural causes that could be leading to this head pain at the back of the head. So other problems that might have symptoms that look like occipital neuralgia could include something such as tumors or infection, congenital abnormalities, Chiari malformations, other primary headache disorders, migraine, tension type headache, cluster headache, hemicrania continua, and then referred pain from either the neck joints or the muscles. And so we want to think about those two and make sure we're not missing something else other than occipital neuralgia. So we have determined this is occipital neuralgia. How do we treat it? There are many treatments available for occipital neuralgia. Some are in the scope of a neurologist's practice. Some are more in the scope of a pain management practice. But kind of first line, what we think of is physical therapy. So working on posture, stretching and relaxation exercises, things that help address what we call myofascial pain, which is pain related to muscle tension and knots. So that can be helpful for people. Sometimes even a good occupational therapist can be helpful, looking into ergonomics with daily life skills. And then there's medication. So NSAIDs, things like ibuprofen, naproxen may provide some temporary relief, but we really think about medications being these medications that are neuromodulating, or they have an effect on the nerves. And so these include medications like tricyclic antidepressants, which would be things like nortriptyline or amitriptyline. We think about serotonin and norepinephrine reuptake inhibitors. So things like duloxetine, or you may have heard of that, called Cymbalta. Another one that we think about from that class would be venlafaxine, which is called Effexor. And then some anti-seizure medications, so things like gabapentin or pregabalin, may be helpful as well. And then another commonly used treatment within a headache specialty clinic, for example, or a neurology clinic, would be nerve blockade. So this effectively is where we take an anesthetic medication. So it would be something like lidocaine or bupivacaine, and some providers use a combination of them, and they inject that numbing medication into the area where the occipital nerves are and numb up that nerve, and that can provide relief. And so, as we mentioned, that's part of the kind of diagnosis of occipital neuralgia, but it also can be used therapeutically. And some people only have benefit for the duration of the medication, but actually 15 to 36% of people that have had nerve block actually report having relief for several months. So it could be a good therapeutic medication for some. Onabotulinum toxin A, which is also called Botox, is another potential treatment. It is hard to get for people unless they have also chronic migraine, but that may be a possibility. When people respond to nerve blocks, but they're not lasting very long, sometimes then we'll have them go on to see a pain management specialist to see if there's more of a longer term treatment. And so they may recommend something called pulse radiofrequency or thermal radiofrequency ablation. And effectively with those treatments, they are using heat or electrical stimulation to stimulate that nerve and kind of desensitize it or turn it down a little bit. So with the form that uses heat, there is a risk of having kind of dysesthesias, or those abnormal pain sensations, or kind of like pain due to it kind of injuring the nerve, so to speak, even though it's deadening the nerve. When you do that, that can also create pain there. So you run the risk of that. With pulse radiofrequency, we don't necessarily see that, though some maybe argue that that's not as effective. So they're both modalities. Effectively, if you've heard somebody say they're going to burn the nerve, that is the treatment that they're referring to. Some other treatments that exist, and these get more into controversial treatments, would be neuromodulation. So for primary headache disorders, there are 5 neuromodulation devices that are FDA cleared and commercially available. And you can learn all about those in my talk from about a month ago on neuromodulation devices on Headache School. But we don't really have evidence for those neuromodulation devices for occipital neuralgia. So somebody might try to use them and maybe it would help, but we don't really know that information. But there have also been studies done on implantable nerve stimulators, occipital nerve stimulators, that could potentially be used. And they also may work, though challenges with them are, risks like the leads, which is basically where the stimulators are placed within the skull, could move. And so then they wouldn't be effective at that point, or they could become infected. So those are risks with those. Another treatment that exists is ultrasound guided cryoablation, so using cold to deaden the nerve. And the same risks that we could see with burning the nerve, you could also get with freezing the nerve, so to speak, is that if it injures the nerve, you could actually run the risk of increasing pain. And then the kind of last resort, many institutions won't recommend this. And I don't tend to recommend this to my patients either, but there is something called surgical decompression that some neurosurgeons will do, where they're trying to remove basically some of these small muscles at the back of the head from pushing on the nerves. But these really run the risk of having more pain afterwards and not necessarily treating the pain that already is there. And so it's kind of considered this like last resort option, and many people won't recommend it. But I included it in here because there are people out there that do this, and so you may have heard of it, but it's one that we would tend not to recommend. I kind of talked about these complications of treatments as we went through, but some of these treatments can worsen pain. With nerve blocks, people can feel dizzy. They may have some pain at the injection site. And then if they're using steroids in their injection and not just the numbing medication, over time, you could see some hair loss in that area where the injection is. Because of that reason, I prefer to use just the numbing medication, but some providers do use the steroid in it. With the implantable nerve stimulators, as I mentioned, you can have migration of the leads and infection. And then with surgery, also, as I mentioned, this is considered a last resort. And there's really a risk for worsened pain, basically due to damaging the nerves from surgery. Even though you're trying to help the pain, you could have worsening pain. So many places won't actually recommend this. So what do I do if I think I have occipital neuralgia? Well, the first step, if you think you have occipital neuralgia, is to actually talk to your doctor about it. You know, your primary care doctor, if you have a neurologist or a pain management doctor, talk to them about it. Give them a really good history of your symptoms. They can help determine based on that, you know, is this occipital neuralgia, or is it something else that looks like occipital neuralgia? And they can do an examination and determine if there's other testing that you need done to look for kind of other causes. But that's the main thing. If you think that you have this, talk to your doctor about it. And with that, thank you for listening. I hope you enjoyed this talk.